A 38-year-old pregnant lady presents with sudden onset left upper quadrant abdominal pain and hemodynamic instability. I am showing you an axial CT angiogram scan. Describe the findings.
Okay. The axial CT angiogram demonstrates a well-circumscribed aneurysm in the left upper quadrant arising from the splenic artery. Slightly hyperdense free fluid is visible within the peritoneal cavity, representing a hemoperitoneum. There is significant surrounding fat stranding adjacent to the aneurysm, indicating leak or acute rupture. The spleen itself appears intact but displaced by the hematoma.
I am showing you catheter coeliac angiogram images. What do they demonstrate?
Okay. The catheter angiograms show a large aneurysm arising from a highly tortuous splenic artery in the left upper quadrant. There is a focal defect at the inferior wall of the aneurysm calcification. This is associated with active contrast extravasation, confirming ongoing retroperitoneal or intraperitoneal hemorrhage.
I am showing you the final treatment image. Describe it, state the diagnosis, and discuss the vascular classification.
The subsequent spot catheter angiogram demonstrates successful endovascular coil embolization of the splenic artery aneurysm. There is successful occlusion and exclusion of the aneurysmal sac with complete cessation of active extravasation. Crucially, contrast perfusion shows preservation of some splenic tissue via collateral circulation. The diagnosis is a spontaneous rupture of a true visceral artery aneurysm of the splenic artery. Visceral aneurysms are classified into true aneurysms, involving all three vessel wall layers, and pseudoaneurysms, which represent a contained hematoma.
What are the risk factors for splenic artery aneurysm rupture? How do we manage asymptomatic true aneurysms?
Risk factors for rupture or enlargement include pregnancy, portal hypertension, and liver transplantation. For asymptomatic true splenic artery aneurysms, conservative follow-up with annual ultrasound or CT is advised if the size is under 3 centimeters. Treatment is indicated if the aneurysm is 3 centimeters or larger, or in patients who are pregnant or planning pregnancy. Endovascular coil embolization is the preferred minimally invasive modality, while surgical excision or splenectomy is reserved for cases with hemodynamic instability.
What are the key clinical differences between a true splenic artery aneurysm and a splenic pseudoaneurysm? How would you manage this patient as a radiologist?
In that case, splenic artery pseudoaneurysms almost always present with symptoms and are commonly associated with pancreatitis, trauma, or surgery. In pancreatitis, released proteolytic enzymes cause necrotizing arteritis and wall destruction, necessitating treatment at any size due to high rupture risk. As a radiologist, I would recommend immediate transfer to the interventional suite for urgent endovascular coil embolization. I would also recommend post-procedure follow-up CT in 2 to 3 months to assess for residual viable splenic tissue and ensure proper vaccination against encapsulated organisms.